So just a quick review of EKGs. This is just those EKGs that I think are pertinent to Capstone course. I know you've covered them already. I'm not an expert on EKGs. I'm not an expert on anything, but this is just a quick review. So let's look at this. This is a normal looking EKG. First, whenever we are reading an EKG, we got to look at the rate and the rhythm. So you can see the rate is pretty nice and normal. This is about 300, 200, so it's about 75 beats per minute. Rhythm is really normal because you can see that every QRS complex is preceded by a P wave everywhere in all the leads, so that is a normal rhythm, and it's also a regular rhythm. So that's a normal sinus regular rhythm. That's how we just see rate and rhythm. The next thing, that's the most important thing, we need to look at any sign of ischemia or infarction. So for that, it is a good idea to divide the EKG in different segments. The lead 1 and AVL are going to represent your lateral wall. 2, 3, and AVF are going to represent inferior wall. V2 and V3 are going to be your anterior wall, and then 4 to some extent will be anterior wall 2, and 5 and 6 are going to be lateral wall again. V1 is going to be septal wall, and then your AVR is going to be right ventricle. So basically that's how you look at all these leads, and these correspond to different walls. Whenever there is any STT change or Q wave, then wherever it is present in the EKG, then you say, okay, that part of the myocardium is injured. So looking for the ST segment depression and T wave inversion, we look at the contiguous lead. So it has to be at least more than 2 contiguous leads, and if the ST segment is depressed below the baseline, more than 1 small box deep, then we say it is ischemia. And if it's T wave is inverted in more than 2 contiguous leads, then we also say it is ischemia. So it doesn't have to be both depression and T wave inversion in order for us to call ischemia. It can be one or the other, ST segment depression or T wave inversion. So that's how we call ischemia. Now also remember that T waves are going to be inverted in some other situations too, even in the absence of ischemia. For example, we know that in hypokalemia patients, and also patients who have sustained hypertension and left ventricular hypertrophy, sometimes there is strain and T wave is inverted. So that doesn't necessarily mean ischemia. Usually ST segment depression is more representative of ischemia. So the infarction is represented by a Q wave. So after 48 hours or more have passed, then we say, okay, Q wave would be present. So there is a normal Q wave, normal physiologic Q wave, that is represented by a small q. That is basically normal, nothing to worry about it. This, the definition of this Q wave would be that this is supposed to be less than 2 small boxes deep and less than 1 small box wide, or less than 1/3 of the R wave. So if you just remember 2 and 1, so more than, if it's less than 2 small boxes deep and less than 1 small box wide, then that is a normal Q wave. Anything bigger than that is basically a pathologic Q wave. So whenever Q wave is present, it means more than 48 hours have passed since infarction. Less than 48 hours basically would mean, or acute infarction basically would mean that ST elevation will be elevated. I mean, ST segment will be elevated. So this is a pathologic Q wave, and you can see that there is more than 2 small boxes depth of this wave, and then we, in this case, we will call it definitely pathologic infarction or pathologic Q wave. You can see in this situation the ST segments are not elevated, so this probably is old infarction. So to determine if an ST segment is elevated or not, we will look at the ST segment itself. Of course, it is supposed to be a normal upsloping segment, and then also the segment has to be on the baseline. If the entire segment is elevated above the baseline, let's say the J point starts here and the entire segment is elevated above the baseline, then we'll call it ST segment elevation. Or if we see that there is an upsloping where there is a convexity of the ST segment, and there is a sad phase, basically this is making a sad phase, we call it ST elevation. If it's making a happy phase, although it is upsloping and it appears to be slightly above the baseline, we don't call it ST elevation. Basically, it's a happy phase. It's making right here, so we will call it normal ST segment. The elevation either has to be the entire segment above the baseline with the J point, or there has to be a sad phase. See here, lead 1 and AVL show that there is ST elevation. So although this is not a sad phase, but because the entire segment is elevated above the baseline, including the J point, this was the baseline, that is why we are calling it ST elevation. So either it has to be this or it has to be a sad phase. So we are calling it lateral wall MI. So you can see both 1 and AVL ST segments are elevated, and then reciprocally 3 and AVF are basically inverted or depressed. So you can see reciprocal changes. But anyway, for elevation, you just look at these two leads where you can see there is elevation. This is anterolateral wall MI, so you can see in lead 1 and AVL, ST segments are definitely elevated. And then also in basically 2, 3, and V2, V3, V4, and V5, which are basically, these represent the anterior wall. They are also elevated. So that's why this is a massive MI, anterolateral wall MI. So make sure that you pay attention to it and make sure you recognize what part of the myocardium is involved, because this will be important. Even going all the way up to V6, you can see that there is elevation. And then in this EKG, you can see that lead 2, 3, and AVF show ST elevation. So ST segment is elevated definitely way above the baseline, and that is how we are calling it ST elevation. So you can see the entire segment is elevated. It's basically something just pulled it up. So this is real ST elevation. So that was as far as the ischemia and infarction were concerned. Now let's look at the supraventricular tachycardia. So this is just a normal, nice rhythm. You can see every P wave is followed by QRS, and there's just a very fast heart rate. There is no other problem. There is no ST. There's no ST segment depression or elevation or any other problem. T waves are a little bit hyper acute, but they are tall, but it doesn't mean any injury at all. We do see T-wave inversion in 2, 3, and AVF, but that may represent some injury. It may represent some strain, but for the purposes of rate, we can see that the rate is fast in this EKG, and the rhythm is really normal. So every QRS is following a P wave. This is flutter. So with flutter, you just see a sawtooth appearance. Whenever you see a sawtooth in the rhythm lead or overall in the EKG, then we call it a flutter, and you can see there is a 2-to-1 block because not every P wave is conducted. So this is why we call it flutter. And atrial fibrillation, basically there are two things to remember to recognize atrial fibrillation. So the P waves are going to be absent. If you see normal regular P waves occurring at regular intervals, it's definitely not AFib. So you will have to say there is absence of P wave, and the rhythm has to be irregular. If the P waves are absent and the rhythm is regular, then it is either junctional tachycardia or or basically flutter or some other sort of rhythm. For the AFib to be called, it has to be irregular. So let's look at the P wave. So you can see that there are some upward and downward deflections everywhere. So especially, for example, in this lead, this is T wave. One might say that this is a P wave or this is a P wave, but this is not a normal P wave. You can see there is a notch. There is notching. The P wave is not followed by any QRS, and also there is no regular normal morphology of P wave. So that is why we will call it atrial fibrillation, because it's so irregular and the P waves are virtually absent. This is another atrial fibrillation. So you can look at the rhythm lead and you can see it's very irregular. There is no pattern here, and then the P waves are basically absent here. There is some upward deflection in some of the leads, but we cannot call these P waves because there is no, the morphology is really abnormal. This is another one with AFib. So you can see that the heart rate is probably not too fast in this one, but it is definitely irregular. So it is the ventricular rate is basically controlled. The P waves again are absent. There is no normal morphology for P wave. Now ventricular arrhythmia. So this is a ventricular tachycardia. So this is just a normal, not normal, but it's a very typical picture to remember. So just keep this in mind. The VTAC is going to be basically dome-like appearance. So this is a monomorphic VTAC. This can be polymorphic too, where the morphology is changing or undulating, but this is basically monomorphic VTAC. This is torsoides deep pointes, where basically that means turning of the point. So you can see points are turning from here to here to here. It's more like a musical pattern. And this is ventricular fibrillation, where you can see that there is no regularity. We know this is ventricular because there is no P wave at all, and the QRSs are just like broad, and there is no rhythm at all. So we call it ventricular fibrillation. Okay, now let's do the blocks. So first degree AV block basically simply means prolongation of PR interval. Nothing else happens. Everything else is normal. There's just prolongation of the PR interval. That's called the first degree AV block. So it's more than 200 milliseconds. And then second degree AV block, or Mobis type 1, or Wenckebach block. So remember those names, Wenckebach or Mobis type 1. Second degree block is going to be when we see that there is progressive prolongation of the PR interval until the QRS complex drops. So the PR you can see is getting longer and longer, and then finally the QRS is going to drop here. So that's how we call it Mobis type 1 or second degree AV block, and also called Wenckebach. So Mobis type 2, which is also second degree AV block, is basically happening whenever there is random dropping of the QRS complex and there is no progressive prolongation. So you can see PR intervals are pretty constant, but then all of a sudden one QRS drops. And third degree AV block is where there is basically complete dissociation between the atrium and the ventricle. So no P wave is conducted. You can see P waves are happening on their own, and the QRS complexes are happening on their own. For this to occur, we have to see a rate of less than 40 beats per minute for the ventricles. So if it's more than 40 beats, then we cannot call it third degree AV block. So you can see here 300, 200, 150, 75, 50. So it's definitely less than 40 beats per minute. So this is it. So this was all about EKGs, just a brief overview, and this is all that is required. I hope this was helpful. Thank you.